Well, good afternoon, everybody. I think you're going to need your headsets. Or maybe you don't. So thank you all for coming. Ladies, gentlemen, friends, colleagues, ex-colleagues, it's really exciting to, again, be here at ASCO and being able to present some of our work to you. Today we really have three topics that all tie together, I think, in a very nice fashion. And I'll walk you through those, and there really are sort of three separate topics. One is the mechanism of action of DCVax. We've talked about that a little bit in the past, but we haven't really filled you in on all the work that we've been doing to demonstrate that DCVax indeed has all the characteristics that it needs to induce the immunological and clinical effects that we're all seeing and we're expecting. Then I'll highlight the immunological effects that we're actually seeing in patients. And I'll talk a little bit in depth about the clinical trial external controls methodology. And I truly believe that we're at the beginning of a revolution here, where hopefully 5 or 10 years from now there will be no more need for placebo-controlled clinical trials. Because really, in the end, once you know sort of what the outcome is of a disease, especially if the patients are given standard of care, at some point there will be no more need for placebo controls, and all patients will be able to participate in the new inventive treatments that we're all coming up with. And we think that's an important development, and we're happy to be one of the leaders in that particular field. This is the obligatory disclaimer. Don't read this whole thing. This is the overview of the presentation. I'll first give an introduction about DCVax L. A lot of you are familiar with the product, but I still think it's useful to give you a bit of an introduction because that leads into the rest of the presentation. The mechanism of action, I'll go into some detail, and therefore first I will again give a bit of an introduction on what the mechanism of action should be, and then I'll show you that it actually works in the way that we expect. Again, for some of you that will be a bit repetitious because you may be familiar with it, but because of some of the detailed explanations I'm giving later, I think it's still useful to go through that. The immune monitoring section is entirely new to everybody here in the audience. And then I'll talk rather extensively about the use of external controls in clinical trials and some of the things that we did that we believe are important also for other people to follow, so that the design can be and the execution can be sufficiently rigorous and well controlled. I'll talk about two of our compassionate use cases and make some observations about that, and then of course I'll end with some general conclusions and a broader perspective. So what is DCVax L? DCVax L is composed of autologous dendritic cells that are loaded with autologous tumor cell lysate. So both components are autologous. The tumor cell lysate is the source of the antigens. They come from the patient's own tumor. We use the tumor tissue that is resected at the time of surgery to make the lysate. So it comes from the patient, it goes back to the patient. The dendritic cells come from the white cells that are in the blood. We obtain that through a leukapheresis. And we need that because the immune system of the dendritic cells needs to match with the immune system of the patient once we give it back. So if you give dendritic cells from somebody else to a patient, the likelihood is that that match will not be there, and therefore you don't get the stimulation of the immune response that you need. The tumor lysate, we prefer that very much over using a limited number of antigens, because tumor lysate is a broad spectrum source of antigens. Every single antigen that's present in the tumor will be present in that lysate. And I'll show to you the evidence why that is actually important. For one, the reason is that, at least we presume, that it makes it more difficult for the tumor to escape from the immune attack that we're targeting. But of course, therefore, we need to show that we actually have a broad array of antigens, but also that the patients are responding to a broad array of antigens. And I'll show both of those factors to you later in this presentation. And of course, the tumor lysate provides the correct antigens and not the wrong antigens. It's intended as adjuvant treatment following surgery. We need the tumor cell lysate from the resected tumor to make the treatment. And we have used it to date to treat almost 600 patients with GBM, both in clinical trials and in compassionate use programs, and also tens of patients with other cancers, including Merkel cell carcinoma, breast cancer, thyroid cancer, and several others. The trial results from the phase 3 trial have now been published in JAMA Oncology, with Dr. Linda Leal from UCLA as the first author. showing both clinically meaningful and statistically significant extension of survival in both newly diagnosed and recurrent GBM. And just to tell you a little bit about the manufacturing, of which I gave a long presentation last year, manufacturing takes about 8 days, provides several years of doses that are frozen down and can then be shipped as an off-the-shelf treatment to patients over time. And that's exactly how we did it in the clinical trial. So how is DCVax L supposed to work? How do the dendritic cells actually interact with the T cells and induce the immune response that we're after, leading in the end to the induction of cytotoxic T cells that can travel to the tumor and kill tumor cells? One of the hallmarks of this mechanism of action is the so-called multiplier effect. One dendritic cell leads to hundreds and hundreds of T cells that are responsive to the tumors. And how does that actually work? So the dendritic cell takes up and, this pointer doesn't, there it is, takes up and presents the tumor target proteins from the lysate in the context of its own MHC molecules. And I'm not going to talk about MHC, but that MHC word is important because that's how the antigens are being presented. Then the antigens are presented to the anti-cancer T cells that become activated because the resting anti-cancer T cells attach to the dendritic cells through a number of molecules called costimulatory molecules. Those activated anti-cancer T cells then divide rapidly, that's the multiplier effect, and acquire a capability to kill tumor cells, something we call cytotoxic activity. And then those multiplied T cells then can travel anywhere, including to the brain. Activated T cells are one of the few agents that can actually travel across the blood-brain barrier. If you've heard about drug development for glioblastoma, you know that the blood-brain barrier is a huge hindrance towards the development of drugs, because most drugs, well, actually you can inject them, you can ingest them, but they won't get to the brain. Whereas activated T cells travel everywhere, including to the brain and including to the tumor. And we have evidence, I'll show you a picture, that they actually end up there and start killing the tumor cells. So let's first talk about antigen uptake and presentation, because yes, we incubate the dendritic cells with the lysate that contains the peptides and the antigens, but how do we actually know that those peptides and antigens are taken up by the dendritic cells and then presented on their surface? And this is a series of experiments that show you how we actually have gathered that information, how we know that the information I just told you is actually correct. So we did proteomics analyses on the following materials to determine protein content and diversity, a very important key word here. We did proteomics, i.e. proteomics means that you characterize every single protein that's in that particular preparation. So proteomics on the tumor lysate will tell you every single protein that's in the tumor lysate. We used unpulsed dendritic cells, so dendritic cells never incubated with tumor lysate, but also dendritic cells that were pulsed with tumor lysate. And then we did another trick. We took the peptides off of those dendritic cells and asked what's in those peptides, because then we know what's actually being presented. So from a single sample, this is one experiment that we did, we found that there were 25,000 MHC class 1 associated peptides. Those are short peptides that are important for cell killing. We also found almost 13,000 class 2 associated peptides. Those are more important in inducing T cell help. Helper T cells and cytotoxic T cells interact to induce the tumor killing effect. Of those 25,000, a lot of those were upregulated on the dendritic cells after pulsing, suggesting that they actually came from the tumor lysate. And the same is true for 7,000 or more that were more abundant on dendritic cells after pulsing. That's not everything, because then we found that we had 399 tumor-associated peptides, 400 different tumor-associated peptides. So these are all presented on the dendritic cells. They're all presented to the immune system. The immune system now has the capability to react to every single one of those antigens. So we truly do get a broad-spectrum immune response just by the function of using that tumor lysate to pulse the dendritic cells, rather than what has been tried many other times, using a single antigen or a small repertoire of antigens. And some of those peptides that you can see that are either twofold, threefold, fivefold enriched on those dendritic cells are listed here. These are just amino acid sequences. I don't expect you to read those. And these are just examples. For MHC class 2, like I said, important for the interaction with the helper T cells, there were 220, and these are the ones that are detected. There is a certain limit of detection, level of detection as well here, and anything below that limit we won't be able to detect, but they can still be there. So this is a low estimate of the number of tumor-associated peptides that are presented by these dendritic cells. Remember, these are the ones that were taken off the dendritic cells, so these are the ones that are actually presented. And we've got a few examples here again as well, with the degree of upregulation on a 2-log scale. So where does that take us? These are some antigens that we found, because once you have those amino acid sequences, you can go to a database and you ask, where does that amino acid sequence come from? Which protein was that derived from? And we found, not to our surprise, that there were peptides that came from proteins that were previously identified in glioblastoma. Okay, so you take a tumor lysate from glioblastoma, you put it on those dendritic cells, you find antigens that were already known to be associated with GBM. Interesting, exciting, not that novel perhaps. Some of those is an inhibitory protein known for GBM. One, I really love this name, the disheveled associated activator of morphogenesis number 2. There must be a number 1 out there somewhere as well, which promotes gliomagenesis. So these are known MHC associated, GBM associated peptides. So what else did we found? We also found examples of peptides that were known to be associated with other tumors. So if we had taken a repertoire of known GBM proteins, we would have missed these, because we would have never anticipated that these would be presented by dendritic cells and that these might be as relevant for the activation of the immune system against GBM as the ones that were known to be associated with GBM. My motto is always, don't pretend to know more than you do. And this was something that we truly did not know before. There's this ligase that's expressed in multiple cancers, a protein associated with poor prognosis in ovarian cancer. So attack against these tumors might attack GBM as well, and probably will attack GBM as well. So a few of the summary observations are that the lysate preparation releases multiple cancer-related proteins from which these peptides can be processed. Sorry. Like many of you, I'm still recovering from a cold. These dendritic cells pick up, process, and present hundreds of tumor-specific peptides to T cells, literally hundreds. Imagine now that you're a tumor and you're attacked from 100 different sides. It's almost impossible to downregulate those targets and escape from that immune pressure, which is why we think the product works as well as it does. It presents peptides from both known GBM-associated tumor antigens and tumor antigens which have not been reported in GBM before. And the presentation of these peptides not only through class 1, remember, important for cytotoxic T cells, but also through class 2 to CD4 T cells, suggests that we also get T cell memory responses in vivo. Something, of course, that we believe is incredibly important in a chronic disease like GBM, where you can't just eradicate it at once. You need that ongoing response that continues to hammer away at the tumor. You need to set up that battle in the brain where the immune system can continue to eradicate tumor cells, because they will continue to replicate otherwise. So this immune memory is actually critical for the potential success. So now we have these, in the context of MHC class 2 and MHC class 1, we have these peptides that interact with the T cell receptor. But that's not sufficient for a dendritic cell to activate the T cell. We need at least 2 signals. In fact, we need 3. But I'll only talk about 2 today. We need the T cell receptor with the multiple peptide antigens. We just demonstrated that happens. But we also need co-stimulatory signals. We have CD40 here, we have CD80 here, CD82 here. They're given different names here, but they're the same proteins. And we need those because the T cell, like I said, needs at least 2 signals to become activated. So what do we know about those? What you see here on these little plots, this is an indicator for the size of the cells. It's called forward scatter on the x-axis. And this is the degree to which the cells label positive with the different markers that we have here expressed on the y-axis. In this case, it's CD40. Here it's CD141. So if they're sitting in the top right corner, you can see that they're large cells, they're moving in this direction, and they're positive for this particular marker. So for CD40, CD141, CD82, CD86, MHC class 2, we have these pictures. We have it for many more of these particular kind of markers that are so critical for those interactions to have a positive outcome. So here you see the function of those molecules. CD40 interacts with CD40 ligand. CD41, 141 is directly involved in antigen presentation. CD82 stabilizes dendritic cells interactions. The longer those interactions take place in the what's called the immunological synapse, the stronger the T cells will be activated. So all of these molecules are critical for this, for the effects that we're seeing. And then there's CD83, which is a marker for activation or maturation of dendritic cells. Immature dendritic cells don't activate the immune response very well. Mature or activated dendritic cells do, and we show that our cells do express CD83 as expected. So then the question is, okay, now we've got all this, right? We've got the peptides on the class 1 and class 2 molecules. We got the costimulatory molecules. What has actually happened when you put those cells together and you stimulate and re-stimulate them a few times in vitro? Can we now actually generate cytotoxic T cells like we're hoping that we're going to be doing in the patient? The short answer to that is yes. These are complicated experiments. This was done by Daphne Friends and Mark Lodell. And you can, I'll just make this relatively short, but you can see that if you have all the right components here, which is the lysate from the MCF7 cells, the mature dendritic cells, and you have the T cells present, that you get a degree of cell killing that kills 60% of the cells. It doesn't work if you leave out the lysate. It doesn't work if you leave out the T cells. It also works if you use only the CD8 positive T cells. So you don't need CD4 cells at the end of the cell killing process. You do need them to get to that stage. And you can do that assay for either 16 hours or 24 hours. At 24 hours, your background becomes a little bit more disturbing. So we tend to do these in a relatively short period of time, like 16 hours. So we find that killing of target cells is observed if the T cells were stimulated by dendritic cells loaded with tumor cell lysate. So yes, we have all the components. Now we show that they actually work the way that they're supposed to work. But that doesn't mean that we're getting a lot of T cells yet. This is work done by Leekna and Andrew at Flaskworks, the company that was helping us present last year. They're both here in the audience. This is what we call the multiplier effect, or at least it's evidence of the multiplier effect. Whether it is the multiplier effect, we really don't know at this point in time, but it's strongly suggestive. What this is a T cell stimulation assay where T cells are dividing, and every time they divide, they move a little bit to the left in this spectrum. This is a dye that gets diluted. So every generation of T cells has its dye diluted by twofold, and therefore you get all these multiple peaks. And you see that there's like first generation, second generation, third generation, fourth, etc., etc., etc. For this particular question, we're mostly interested in the late generation T cells, because those are the ones that have undergone the most division, so they have the most daughter cells at this point. So what do we see when we do this assay with T cells loaded with lysate, dendritic cells loaded with lysate, or dendritic cells not loaded with lysate? We see that the dendritic cells loaded with lysate, these ones here, generate significantly more of these late generation T cells. So there is an additional T cell stimulatory capacity that we still need to identify and still need to understand, but it's something that we observed and we think that is very interesting and could be, at least in part, responsible or co-responsible for the multiplier effect that I told you is so important for the mechanism of action. So the conclusion is that these lysate-loaded dendritic cells have acquired this additional T cell stimulatory capacity, which result in more late generation T cells that we need to fight the tumor. More is better in this particular case. In summary, the dendritic cells in DCVax L express the requisite costimulatory molecules for this productive interaction. They also express CD141, a molecule involved in effective antigen presentation to T cells. If we mix those dendritic cells, the loaded ones, with the tumor lysate, then we have this additional T cell stimulatory capacity, and we can then induce killer T cells, the CTL, cytotoxic T lymphocytes. And the combined these effects enhance the multiplier effect, or are responsible for the multiplier effect. In conclusion, mechanism of action studies demonstrate uptake presentation of a broad range of antigens, which is important to prevent tumor escape. And I will next talk about the immune monitoring data that demonstrate activation of a wide repertoire of T cells which can travel to the brain. This is data that we have not shown to you before. So, what is in vivo immune monitoring? What we wanted to know is when we inject these dendritic cells into the patient, what happens to the T cell response? Are we inducing a T cell response? The hypothesis is yes, that we are. Linda Liao has shown that in the past, that indeed in her early stage trials this actually happened, but that's really proof of concept. That is, okay, if I do this and I do some complicated experiments, then I can demonstrate it actually happens. What we did here was take all of the T cells from a patient out of the blood, well, not all of the T cells, but let's say several million T cells, and ask, are they expanded? Are they not expanded? Has T cell expansion occurred like we expect? What is happening in these patients? Here's the experiment that we did. Because we used a broad spectrum immunological stimulatory approach with all the tumor antigens that I just explained, we also use an analysis that allows monitoring of the entire T cell response, as opposed to monitoring the response to a single antigen. Single antigen is easy to do. This is hard to do. Okay. Now, what you need to realize is each T cell that emerges from the thymus during ontogeny, during development, has a unique T cell receptor DNA sequence. So, before you get hit with any pathogen or any infection as a young kid, you have all these T cells circulating, and whenever you get an infection or another stimulation, the T cells that respond to that pathogen are the ones that start to expand. And that's how you can fight an infection. That's how you fight the coronavirus, for instance. So that's a normal process that happens during a response to an infection. We are asking the question, does it also happen in response to DCVax? The hypothesis was that it did. But of course, when a T cell divides in response to stimulus, that specific T cell DNA sequence becomes more numerous. It's a T cell that has a specific DNA sequence T cell receptor and multiplies 1,000 times, you now have 1,000. So sequencing all the T cell receptors allows you to identify newly expanded T cell clones that weren't there to begin with, or identify T cell clones that have further expanded, like from baseline. Here's some of the data from 3 patients. What you see here is the number of expanded T cell clones between baseline and month 4 or baseline and month 8. Now, remember, we give several immunizations. We give day 0, day 10, day 20, month 2, month 4, month 8. And so, and then we measure at discrete time points what happened to the T cell repertoire. And here we measure the number of expanded T cell clones. And you can see that between baseline and month 8, 800 T cell clones have expanded in this particular patient. More interestingly, about 250 of those expanded ones had never been seen before in that patient. So they weren't there at baseline, at least not at a detectable level. They're now very detectable at month 8. This is a newly induced T cell response. This is enhancement of a T cell response that was already existing. We think that both are important. Glioblastoma is not known to be a very immunogenic tumor, but it doesn't mean that it does not induce a bit of a T cell response already. It's sitting in the brain, it's well protected from the immune system, but that protection is not completely 100% black and white. So it's not surprising that there are already T cell clones present in the patient that we are expanding once we immunize it with the lysate from the same tumor that the patient already carried in his brain. Patient 2 had also about 800, and this patient is really taking the cake. It's more than 1,200 expanded T cell clones, of which 500 or more are new that weren't seen at baseline. So these bars represent the total number of expanded T cell clones, as well as the pre-existing. And yeah, thank you. I'm getting my medication here. You need to take your drugs. That's what they tell me. Now, the background in patients where we would not be doing this is roughly 2 to 20 clones. I'll show you a picture to illustrate that. So this is the background stimulation. This is what's happening when you give DCVax. Here's a more sort of better illustration of the T-cell dynamics. You're all probably old enough to remember the old 1980s commercial, this is your brain on drugs. Well, this is your blood, and this is your blood on DCVax L. Sorry, I had to throw that in there. Here you see, so in orange, here you see expanded T-cell clones, and here you see the converse is contracted T-cell clones. So T-cell clones that were detectable at baseline but are now detected in smaller numbers. They don't disappear. They get outcompeted by the ones that are expanding. And so you see in a normal patient between sort of time 0 and month 4, you see basically almost nothing happening. There's one newly expanded T-cell clones here, there's 2 that are contracting. Here you see literally hundreds that are expanding, and the ones here on the left are all the new ones. And here you see the ones that are less numerous following the stimulation. So there is a shift in the T-cell response. There's a dynamic going on that results mostly in the generation of a new immune response against the tumor antigens presented by DCVax. Oops, sorry. Here's an example of 3 patients, and these 2 are very strong responders. You can see that, all these new clones here, all these expanded clones here that were already existing. Same for this patient. This patient, like any drug, is a slightly less strong responder. You still see new T-cell clones, you still see expanded T-cell clones. It's still quite different from the patient where there had been no stimulation. It's not as potent and not as powerful. And of course, we're very interested why some patients respond stronger than others. This is true for any drug and every drug, so it's not a surprising finding, but we think it's a very interesting finding. This, by the way, is a comparison between baseline and month 8. Very exciting. Once you have these T-cell receptor sequence, you can go to a database and you ask, oh, that T-cell receptor, is that known to already be associated with a T-cell response that has already been characterized to a known antigen? Those algorithms and those predictions are, I would say, they're limited, and they're only indicative at this point in time. But within that, we could still make the following observations. We found T-cell responses that were potentially responding to a very broad range of antigens. Not surprising, we give a broad range of antigens, we get a broad T-cell reaction. The predicted epitopes include several known tumor antigens, surprise, surprise, some known to be associated with GBM, but some not previously identified in GBM, just like we found in the proteins presented by the dendritic cells. We also found several viral antigens, both CMV and EBV. And both CMV and EBV have been found in the past to be associated with GBM, so that's not a surprise either. And then we found multiple molecules that we really don't know what they do, so we'll be looking into that some further as well. Then this is a picture that you may have seen before. This is a picture by Linda Liao that she shows a lot, and I've shown it a couple of times. This is a section of the brain tumor from a patient operated post-vaccination. And you can see that post-vaccination, you have a lot of T cells that are getting actually to the tumor. There's very few prior, there's a lot after, and it includes both CD4 cells and CD8 cells. So now we have the whole chain complete. We know how dendritic cells work, we know what they present, we know how they interact with T cells, we know the induced T cells, responses, expansion in the patient, and we now know that they actually make it to the brain. So that completes the whole sequence of events that's important for how the dendritic cells and the specific DCVax works. So just a summary of these data before I go to the clinical trial. T-cell receptor sequencing demonstrates extensive expansion of specific T-cell clones in response to a broad repertoire of antigens. And I love this quote, so I put it in. This was by the technician of the company that actually did this work. He said, this level of clonal expansion, especially of the new detected clones, provides strong evidence for a novel stimulus of the immune system during this interval. I couldn't have said it better myself. So these observations together all support the postulated mechanism of action of DCVax. So let me move on to the clinical trial methodology. I'll just mention the data real quick to you. Most of you are familiar with the data, so I'm not going to spend much time on that. But one thing that was overlooked by a lot of people that had the chance to read our paper in JAMA Oncology was that there was a lot of methodology explained in the online-only supplement, but I understand that not everybody gets to the online-only supplement. And it also introduced some new statistical methodologies that are not typically used in health economics analysis, but not always used in analysis of clinical trial data. So therefore, we thought it would be useful to spend some time on those here today. Now, of course, you are aware, of all of this. Primary endpoint is overall survival in newly diagnosed GBM versus external controls that I will be talking about next. And the secondary endpoint is in recurrent GBM, also compared to external controls. There's good reasons to use external controls. I won't go into that. That's all extensively explained in the paper. And these are just the two observations that the findings in both newly diagnosed and recurrent disease are both clinically meaningful and statistically significant, showing extension of survival, in this case of about 3 months, in this case of more than 5 months. And a 5 months increase in survival in recurrent GBM is not something that you see every day. Just the landmark survival data, you see that we have a more than twofold increase of the relative rate of survival at 5 years. 5-year survival in GBM is a rare finding in any case. And in recurrent disease, 30-month survival of 11%, i.e. a doubling of overall survival. It's quite, we would say, meaningful and significant. So, how did we actually do this? We had the DCVax L trial originally designed with a placebo that was then depleted because those placebo patients mostly got treated with DCVax, so you couldn't do that comparison anymore. But so we used external controls, and we got those external controls for newly diagnosed GBM from 5 other randomized clinical trials in newly diagnosed GBM, where the patients got a treatment, but the other half of the patients got a placebo. We used the data from those placebo patients. Those generate the external controls that then our newly diagnosed patients treated with DCVax L are compared to. Now, then we had a crossover arm by which the placebo patients could also get DCVax. So we needed external controls for that as well. 10 trials with recurrent GBM, randomized controlled clinical trials. There is no placebo in most of those, so those patients got standard of care, mostly, or physician's choice. Again, the control patients from those trials formed the external controls that then the recurrent patients from our trial are compared to. This is a concept that is very important, and that I wanted to explain one more time because it's important background for the rest of the small presentation that I still have left. Now, we showed you how we did the analyses. That was the analyses against external controls, this Kaplan-Meier analyses. But when you use external controls, you have to be conscious of bias. By the way, when you do a randomized trial, you also have to be conscious of bias. That is something that tends to be forgotten sometimes, where people say, oh, it's a randomized trial and therefore it's perfect. It really isn't, and I feel that the field has sometimes lost sight of that. But okay, we are very consciously aware of the fact that we need to control for bias, and we used 4 layers of methods to make sure that we had at least thought about that and addressed it to the extent possible to minimize both known and unknown biases, and to closely match the internal control population and the DCVax L patients. So we matched the comparator clinical trials from which the external control population was drawn, and I'll tell you how we did that in the next slide. Then we validated whether the external control population was a useful and meaningful control population by comparing it to the trials from which we drew those individual control populations, pulled them, and then compared them again to the treatment arm of those trials. I'll show that to you as well. Then we did some sensitivity analyses, because yes, there are known and unknown biases when you do it this way. We are aware of that, we address them. And then we adjusted also for individual patient characteristics. We did not have access to individual patient data. It turns out that there's mechanisms, if you don't have that, to address differences in prognostic factors. It's called the MAIC, Matching Adjusted Indirect Comparison, and we did that as well. So here's how we selected those comparator trials. We used an independent expert firm, and the company was actually not involved in that. We asked the question, what are trials that can provide controls that demonstrate what the outcome is with standard of care for patients that participate in clinical trials. So we set up the criteria, or at least the experts did, 14 criteria, 7 for newly diagnosed and 7 for recurrent disease. They needed to be contemporaneous. We did not want to use historical controls. Standard of care changes. Outcome in disease changes just because surgeons get better, oncologists get better. They had to be contemporaneous, and they were. We needed the reported outcomes in Kaplan-Meier curves. We needed the same standard of care. Now, in TBM, that's easy because everybody gets the Stoop protocol. So if you're on a trial, you get the Stoop protocol. That's what you get. It needed to be a randomized study design. We needed patients that matched in age the patients that we had in our trial. We needed Kaplan-Meier plots available for survival and for subgroup analyses, and they had to be in the English language. The data that we got from here are actually very high quality data because there are very few patients lost to follow-up. It's not that this was muddied because some patients were never tracked for a long time. These patients, we have all the data for all these patients for the whole period of time for all of these trials. Therefore, the comparative studies were actually fit for this particular purpose, to compose an external control arm for our trial. And those comparator trials, not just the criteria for selecting, but the actual trials, were identified prior to unblinding the data. We did not know what the data looked like before the trials were identified by the external experts. This is a critical point. You can't look at the data first and then say, okay, which trials are a good fit for me. You have to do it beforehand, and that's exactly what we did. So, what were these trials? These are trials that everybody knows about because these are the big trials in GBM and newly diagnosed GBM. Dose-dense temozolomide trial, bevacizumab trial and newly diagnosed, the Celldex trial with rindopepimut, the anti-EGFR peptide trial, Tumor Treating Fields by Stoop et al., the Optune device, and ICT 107, which is the Patrick Wen trial. Number of patients in those trials add up to 1,366. That is the power of using external controls. You're not stuck with the 100 patients that you had in your trial that you could use as controls. You're adding tremendous statistical power by doing this, but you're also adding a much more realistic comparison because your numbers are bigger. Look how tight the outcomes are in this trial. Median is 16.5 months. The 95% confidence interval is 16.0 to 17.5 months. If you're a patient with GBM, you're put in a clinical trial, you're given placebo, we know how long you're going to live. This is the answer. In recurrent disease, variation looks to be a little bit broader, but actually turns out that when you match all the numbers, it really isn't. 7.8 months survival for first recurrence, and the 95% confidence interval 7.2 to 8.2 months. So we feel that this is a very, very solid database against which you can compare the outcome of your trials. So this is the validation that I mentioned, where we compared now the treatment arm. This is validation of the external control population. Does the external control population actually work as an external control population? We can test that by comparing the treatment arm of these trials to the external controls as a whole, to the 1,366, instead of to their own internal control population. And it turns out the outcome is exactly the same every single time. All of these trials basically, unfortunately, were negative. There was no survival advantage in any of these trials. And as you can see, if you can see these statistics, the hazard ratio shows that too. They're all very close to 1 or even above 1, except for one trial, the Optune trial. And lo and behold, that was the only trial that was positive out of all of these trials. So whether you compare that trial to its own controls or to the ECP, the outcome is exactly the same, and that's true for all the other trials as well. So the ECP is hereby validated. This is a good external control population. We did the same thing, of course, for the recurrent disease, and the outcome there is exactly the same. Let's talk about biases. Like I said, every trial has biases, and they need to be addressed. And we are aware of that, and we did that. In this case, I'm just giving you an example of a known bias. In our trial, patients who had disease recurrence post-chemoradiation were excluded from the trial. They were often put onto compassionate use protocols, but they were excluded from the trial itself. Now, The 5 trials that we used for external comparisons also excluded external controls, but 2 trials also excluded patients with progressive disease, but 2 trials did not explicitly state that. So we could not be sure that they excluded those patients. So we said, okay, let's remove those from the ECP. Let's not use those. Let's only use the other 3. Does that make a difference in outcome? The answer to that is absolutely not. The hazard ratio, instead of 0.8, is now 0.77. So the effect is actually stronger. The p-value remains exactly the same, and the confidence interval is almost exactly the same as well. One of the known biases hereby addressed and dismissed. Unknown biases. Remember that all of those 5 trials had slightly different inclusion criteria because they're all testing different drugs. So you need to tweak your inclusion criteria a little bit to make sure that your patient population is the right patient population for what you're testing. So they were all slightly different. So therefore, we removed each of these individually one by one to make sure that not one trial, because of its inclusion criteria, may be skewed to data to the extent that it would favor us or disfavor us. And the answer to that is, if you remove each of these one by one, it doesn't make one bit of a difference. Hazard ratio remains around 0.8, a little bit higher, a little bit lower. The p-value still remains 0.001, 0.002. There's an outlier, 0.007. Highly significant, and the difference really is the same that it was before. So what we did in these sensitivity analyses, like I said, this is only one example of one where we address a known bias, is that we actually did address this very carefully, and we come to the conclusion that the sensitivity analyses that we did don't reveal any biases that our data could have been subjected to and that could have skewed to results in one way or the other. And then the last thing we did, because no matter how carefully your comparator trials are chosen, there's always going to be differences in the patient population in terms of, for instance, prognostic factors. We know that age is a prognostic factor, extent of resection is a prognostic factor. We know that. And you can, using the matching adjusted indirect comparison, you can adjust for that. And you adjust for that by, it's actually a very complicated statistical method, but it works really well. Like I said, it's being used a lot in health economics analyses. In Europe, all countries have payers, the HTAs, Health Technology Associations, and they determine whether a drug should be paid for or not. And they use this technology a lot, so it's a well-established technology, but in a slightly different field, related field, and used in reimbursement decisions. It can adjust for even small difference in patient characteristics. The net effect is that the sample size is reduced, so you lose some statistical power, because when you adjust, your population becomes smaller and smaller and smaller every time. Because the differences weren't really that big with the comparator cohort, the loss in sample size wasn't that great, but there was a loss in sample size irrespective. But when we did this for these known prognostic factors, which is quite a bit, age, sex, race, MGMT methylation status, KPS score, extent of resection, or residual disease, we did either one. The difference remains statistically significant. It still favored DCVax. The outcome is still DCVax is clinically meaningfully and statistically significantly better against the pool controls, but also against each of the comparator studies. So again, we addressed the fact whether one study was maybe a strong component in making up this control population. The answer to that is no. Conclusions from these external control methodology sort of enlightenments, I hope. Survival of GBM patients participating in clinical trials as control subject is remarkably consistent. For us, I mean, that's unfortunate for the patient population, but for us it creates a landscape in which internal control populations can be used as synthetic control arms. Against this background, treatment with DCVax L is associated with statistically significant and clinically meaningful extended survival, both in newly diagnosed and recurrent disease. And these results are robust, and they hold up well against multiple analyses to address both known and unknown sources of bias. So that's what I wanted to talk about the clinical trial. And now I just want to highlight 2 cases that we've treated in a compassionate use setting. There are, by the way, several people here in the room that are long-term survivors who have been treated with DCVax L. I think we have a 20-year survivor here in the room somewhere. There he is, Brad. So happy to have you. And there's several more as well, and they will be all in our booth, and if you're interested, they'll be happy to talk to you. So this lady is also here in the audience. Sarah? So these are real patients. These are real people. So Sarah came to us in 2012, had only received chemoradiation and then adjuvant temozolomide, and the first batch of DCVax L was made in 2013. Has got repeated treatments. Here became once every 6 months or so. A second batch was made, and we're now 11 years out. And as you can tell, she's alive and doing well. I don't have that many scans, but I have one scan that looks really clean for those of you who understand what a scan for GBM looks like. No evidence of progression to date. Here's a 70-year-old gentleman. His daughter is here actually. This patient came to us at third recurrence at 70 years old. Third recurrence typically is not a time, that's a time when the doctor tells you to get your affairs in order. This patient had 2 courses of DCVax. I believe the second course of DCVax was made after the 4th recurrence with a new preparation of tumor tissue. And again, this patient is also alive and doing well. And here's a series of scans that shows that the enhancing matter has reduced over time. And this patient here, actually the DCVax was given as a monotherapy. So let me just summarize this part of the talk, give you some broader perspective, and then I'll wrap it up. And then if there's questions, we'll be happy to address those individually with people in the booth. We prefer that over doing it here because it gives us a much more meaningful interaction with people that are truly interested. So these are anecdotal observations, but we think they're meaningful. The drug is well tolerated and can be effective in older patients that you probably not treat with many other drugs at that stage in life, including patients with substantial comorbidities. We've got a few examples of those as well. When patients experience recurrence, we can make a new batch of DCVax L, and those patients can respond again to a whole new host of tumor antigens that are in the recurrent tumor, which may be different from the original tumor because tumors change over time. They have plasticity. But when they experience recurrence, before all doses are used, we can also continue to treat them with the original DCVax, and that can still extend survival. And we think, again, that is because we're presenting hundreds of antigens to the tumor or to the immune system that the immune system can respond to. So, broader perspective, we get a broad spectrum immune response. I think I've made that very clear by now. We think it's suitable for combination with a wide range of other treatments. I did not have time to go into the safety of DCVax L, but it's extremely well tolerated. There were very few serious adverse events that were associated with the treatment among thousands of doses that we have administered both inside and outside the clinical trial. So, good candidate for combination with checkpoint inhibitors, oncolymphocytes, cytokine therapy, chemotherapy, etc. Like I said, when a patient has recurrence, new batches can be made. The treatment targets are not lost. The tumors still have treatment targets. It's not that when you give a small molecule against a kinase, like a kinase inhibitor, if the tumor develops superfluous pathways to overcome that blockage of kinase inhibitor, that you cannot use that drug again. With DCVax L, you can continue to use it. We can apply it to any solid tumor. You saw that even from a GBM lysate, we already got antigens that are present in other tumors. So if we use a lysate from another tumor, we'll get new antigens again that are probably more appropriate to that particular tumor, that will also again contain antigens that we would not have known existed beforehand. It's a very easy to administer treatment. It's administered as an intradermal injection. We ship the treatment every single dose, and it can be and has been administered in community settings. We don't need an academic hospital, even though they can do very well as well, of course. Let me just acknowledge the patients and their families, both patients and families that are here and patients and their families that could not be here with us. The clinical trial investigators, we had 90 hospitals where this trial was conducted, and we're very proud of that amount of collaboration that we found in the field. At UCLA, of course, Dr. Linda Liao and Robert Prince have stood really at the beginning of this particular type of therapy. Dr. Ashkan was the principal investigator in Europe. Mike Scott, Alessandra, and the team at Advent, some of which are here as well. We've got people from Flashworks here, including Lekna and Andrew. Mark and Daphne are not here. We have people from Cognate Bioservices. that have worked on this a lot during the trial, and of course the team at Northwest Biotherapeutics. And with that, I'd like to thank you for your time and attention here today and wrap it up. Thank you very much.